and my interest of areas are pediatric neuroimaging. So today we'll be discussing a few pediatric neuro cases that we have seen at our hospital and the learning or teaching point. I think
Just
my voice is
sorry to
okay
interrupt.
or it's too
Yes,
low.
yes, your voice is quite low, Dr.
Voice. Okay,
Hiren.
I'll
We
try
are
to
not
be
able to hear you now.
yeah. So I'll try to be quite like harsh. Right now it's okay now.
Yes, sir.
Now the voice is okay. Hello. Yeah. So we'll start with the
Yes,
cases.
sir. Yes, sir.
Here is our first case, a 9-month-old boy who is recently consanguineous marriage and normal birth and developmental history. There is no history of HIE, and the child was brought with complaint of gradual regression of the previously learned milestone. So whenever you are reporting any MRI neuro cases, it's very important to take care or look at the clinical history because that will be giving you a clue whether you are dealing with some sort of acquired insult or you are dealing with some sort of genetic leukodystrophy which can be progressive in nature. So that clinical things are very important. So when you see this kind of consanguineous marriages, when you see that there is regression of the milestone which were normal, so that indicates it's a ongoing white matter injury, which is not static that we see in like some sequela of prior insult, which is seen in HIE or hypoglycemic injury. So this kind of clues you should able to understand when the child is brought to you for MRI reporting. So based on this history, there was no organomegaly. The ophthalmologic and fundus examination was normal. So these things also is very important when you are dealing with, for example, certain storage disorders will come with organomegaly and certain peculiar genetic abnormalities. They can have classical ophthalmic finding or they can have some sort of optic nerve atrophy. So that is very useful when we are reading the report because constellation of all this finding will help us in leading to the proper differential diagnosis. So please always be careful or always ask to have proper detailed history about the uh, child being brought to you before reporting any MRI. So here is the child who had hypertonia, a 9-month-old child who had some sort of sudden loss of regression of milestones. So that indicates we are looking for some sort of underlying leukodystrophy, which is giving rise to this kind of all regression of milestone. So the MRI was done, and these are the MRI images. So on MRI images, we can see here that first of all that you have to assess that myelination is normal for that age. So what you are seeing at there are some sort of confluent areas of white matter abnormality which are symmetrical in nature, which are we can see that more in the periventricular and deep white matter on either side, and this is the image at the level of basal ganglia and thalami. So at basal ganglia and thalami looking normal, and you see that the hyperintensity on T2 weighted is markedly bright, which is almost identical to the CSF signal intensity what we see in the lateral ventricle, and accordingly the T1 appears markedly hypo. So one thing is that when you are dealing with or when you're suspecting some sort of white matter disorder, uh, you have to first like try to rule out that whether you are dealing with some sort of acquired thing or genetic thing of leukodystrophy. So when the symmetricity of the nature that indicates that and plus clinical history which favors towards that it's more likely to be a leukodystrophy as compared to the acquired insult which can be sometimes symmetric, but usually the demyelination and infection they are trying to be more of a asymmetric in nature. So that is one of the take home point that when the regions are symmetrical and there is no history of insult, then you might be dealing with some sort of genetic leukodystrophy. So here you have to see that how is the pattern of distribution. So you can see that the pattern of distribution looks like to be more of a periventricular and deep white matter. And if you see carefully, that immediate periventricular area in the central corona radiata region of the frontoparietal lobe, that shows some sort of markedly hyperintense, well delineated area, which looks like almost like a cavitation, and that is markedly hypointense on T1 weighted images. So here, these are the DWI and the ADC weighted images, and in which we can see that the white matter which were bright on T2 weighted images that shows the bright signal on DWI and corresponding low signal on ADC. So that's a true restricted difference. So there are some sort of leukodystrophies which can show restricted difference in acute settings. Mitochondrial being one of the thing, and other things are the organic acidurias or your cycle in the acute phase, Sometimes MLD can show restricted different. Krabbe's also can show restricted different. So there are certain disorders which can show restricted different in acute settings. So you should be aware about that finding. Uh, and your pattern of involvement suggests that it looks like more of a widespread phenomena, which is predominantly involving the white matter. You can see that the cortex and the deep brain nuclei, they are relatively preserved. Your brainstem and cerebellum also was normal in this case. That is not being provided. And this was the areas of cavitation. The cavitation also appears very sharply delineated. So that is also one of the clue that this is looking like more of a some sort of cavitating or cystic leukodystrophy. And in those kind of leukodystrophy, there is a role of MR spectroscopy to pick up certain peaks on MR spectroscopy. So here is MR spectroscopy done at the level of abnormal white matter, and the MR spectroscopy also was taken at the level of basal ganglia. So what we can see here that at the abnormal white matter, you can see there is a sharp inverted peak at 1.3 ppm, which correspond to the lactate peak. So when you see this kind of markedly high inverted lactate peak on 144, and with this symmetrical white matter hyperintensity, which shows areas of cavitation, then you should have a differential of mitochondrial disease, because mitochondrial disease are the common one which can have this kind of appearance with this clinical history. So we raise the possibility of mitochondrial disease in this kind of pathology. These are few more T1 post contrast as well as flare images. Flare images are very useful when you are suspecting some sort of cystic changes, or if you are suspecting some sort of cavitation, then flare images can be confirmatory, and they can delineate those kind of changes much more better in contrary to T2 weighted images, in which everything looks bright. And if you carefully see that the areas which were surrounding the cavitation showed some faint enhancement on post-contact administration. So you should be aware about that. There are certain leukodystrophies which can show enhancement, the mitochondrial being one of them. The other disorders that can show enhancement are the MLD and Krabbe's. So these are the disorders they can have enhancement in the affected area, which you should be aware about. So based on all this finding, the suspicion of mitochondrial was done, and genetics was sent, and genetics they all rule out came out to be IBA57, which is like part of the mitochondrial disease. So you should be aware about like there are certain patterns in mitochondrial leukodystrophy, in which when you see the corpus callosum involvement, the corpus callosum, the middle plate is more commonly involved in mitochondrial, and you will see that cerebral white metal will show rare fraction and cystic changes with well-related rim. That was in our case. And they may show contrast enhancement and restricted difference, which was seen in our case. So this kind of finding you should be aware about. And you must be aware about the leak series, which classically presents with the central deep gray nuclei as well as brainstem abnormality. So that are, these also consider a part of mitochondrial leukodystrophies. So this is a good article that if you're interested, you can go through. It is imaging patterns in characteristic mitochondrial leukodystrophy, which was published in, I think, 2002 was, or if I'm not mistaken, or 2020. Sorry, not 2002, 2021 or 22. I'm not right now remembering the year, but that's a good article to show that when to suspect mitochondrial leukoencephalopathy. So these are certain genetic conditions or leukodystrophies which can present with cystic or cavitary leukoencephalopathy, which includes the isolated or combined mitochondrial respiratory complex gene deficiency. Sometimes vanishing white matter can uh, s- not sometimes, often vanishing white matter can be seen with cavitary disease. Alexander disease also can present with cavitary lesions. Then MLC, that is the megalencephalic leukoencephalopathy, which subcortical cyst, they can have cystic leukoencephalopathy. Uh, uh, Not so common, but Charcot Marie type 2A can present with this. And amongst mitochondrial LYRA mutation also can cause this kind of cystic and cavitary leukoencephalopathy. So these are the examples of cystic or cavitary leukoencephalopathy. And these all have some classical genetic or imaging up correlates that we'll be seeing in subsequent slides. So here is now move on to the next case. Here is a 1 year, 10-month-old child. Again, the history is that the child was having there was a history of having consanguineous marriage, and again the birth was normal. was developed, birth and development was normal till 18 months of age. And suddenly after and febrile illness, the child stopped walking and was not able to stand up. And the child had fall from the bed, and after that, child was irritable and crying. So after that, the extensive neuro examination was done clinically, and that revealed that like it is more likely to be a white matter disease or metabolic thing. And these are the MRI images. So on MRI images, what we can see here that now you can see it's like a diffuse global white matter hyperintensity. And at 18 months of age, you're seeing that most of the white matter is also in this complete extension of the basifrontal and temporal area. But what you can see here that entire white matter from starting from the periventricular to the subcortical fibers, everything was looking hyper intense and bright. And this is the corresponding flare images, in which we can see that on flare images, uh, those which is showing T2 bright, they were showing partial liquefaction of the abnormality, and you are seeing this kind of radiating stripes, which indicates that these are the preserved myelin in the liquefied white matter. Uh, if you see carefully that the basal ganglia and thalami, they are classically spared. You can see that in this case, there was involvement of the bilateral plic as well as the corpus callosum that we can see on the Excel images. Uh, Here are the DWI and the ADC images. So as compared to the previous case, here what we are saying that only at the leading edge of the white matter hyperintensity in the subcortical area, it was restricted different. The rest of the area, which was looking like liquefied, that was showing high ADC value, so that was not a true race secret difference. And if you see here that these are the T1 with T1 intersagittal images, and these are few more D2 coronal and the axial images. So on axial images at the infraventricular space also shows that there was involvement of the cerebellar white matter. And this is the T1 Sag image, which shows that the inner aspect of the corpus callosum blade was more involved, and there was sparing of the outer rim. And this patient also developed some on MR spectroscopy. This is 35T, and this was confirmed on 144 that the lactate peak was there at 144T. So when you see this kind of history with global involvement of the white matter, which is diffused from periventricular to the subcortical white matter, and which shows this kind of radiating stripes and liquefied white matter, in addition to mitochondrial, you should consider vanishing white matter disease also as one of the strong possibility, especially when the child was normal and just a mild after mild febrile illness, the child developed neuroregression. Then vanishing white matter should be there in your cards, and usually they present in this early age group, less than 2 years. So that should be in one of your differential when you are reporting the uh, disease. So anyway, I have told you that what is the most likely diagnosis. So you can put in a chat box which one of this is more likely to be present in this kind of scenario. So either we are dealing with MLC with subcortical cyst, or are we dealing with Canavan's disease, or Alexander disease, or vanishing white matter disease. Please put in a chat box. Okay, so good. Everybody is picking up, and most of you are right. All are saying about D, that is the vanishing white matter disease, which is the answer. And these are the some sort of imaging criteria for the vanishing white matter disease, in which you can see that on flare images, you will see the kind of dots and stripe kind of thing. And when the corpus callosum is involved, it is more limited to inner rim, and it will spare the outer rim. And whenever you see the follow-up scan of this child, you will see some sort of cavitatory lesional brain parenchyma. But here, as compared to the mitochondrial disease, the cavitations are very ill-defined, very irregular in appearance as compared to the mitochondrial disease. So that is one of the thing that you should be aware about. So investigation was done, and ultimately the genetic result came out to be positive for the EIF2B5 gene, that is positive for the leukoencephalopathy with vanishing white matter disease. Right. So this was the case of vanishing white matter disease. Uh, just to show the other disorders which can have global white matter disease and what will be the clue towards specific diagnosis. So when you see that there is some sort of global white matter involvement, plus in addition, then you have to look for other structure environment. So in this case, when you carefully see the deep gray nuclei, you can see that there is hyperintensity of the bilateral globus pallidus and the thalami. So they are looking bright in appearance. So when you see this selective globus pallidus and the thalami environment, it is a global white matter environment. And when you see that MR spectroscopy shows very markedly high Na peak as compared to the choline and creatinine, then it's a classical scenario of Canavan disease. Here is one of the conditions in which there will be global white matter environment, uh, and the child will present with some sort of macrocephaly, but the symptoms will be very minimal, or there may be just a mild motor delay. In contrary to mitochondrial disease or vanishing mitochondrial disease, which has drastic sudden regression of the milestone. Here, the decline is gradual, and the classical finding would be that you will be finding this kind of well-defined, demarcated subcortical cysts, which are more common in the frontal and temporal distribution. And the white matter will be involved throughout. There might be sparing of the internal capsules that we can see here. Here, as I have stated earlier, that when you want to see the cavitation or cystic changes, you should use the flare images. And on flare images, we can see that well delineated cystic changes. And on DWI, here we are not able to see any areas of restricted diffusion. So that also sometimes helps in between mitochondrial or vanishing white matter versus this kind of MLC kind of cases. So a question for all of you: which one which one of this is not a large head leukodystrophy? Is it Alexander? Is it Canavan's? Is it Aicardi Gutierrez or MLC? So what should be the answer? So yeah, so most of you are saying that okay, I'm getting some mixed response, but anyway, majority of you are saying that answer three is correct, which is the correct answer. So the answer three is Aicardi-Goutieres disease. So Aicardi-Goutieres disease basically it's a spectrum of interferonopathy which comes with lot of brain atrophy and which comes with smaller brain volume, and they present with microcephaly. And rest of the other examples what we have provided here, they have usually large head. Now, one of the question that has been asked till now is that on in pediatric neuroimaging, which spectroscopy is preferred? So, which that is a very valid question, and we have like one question is that how to differentiate myoacidosis versus glycine peak. So, whenever the pediatric neuroimaging is concerned, ideally you should take the spectroscopy at low and intermediate T. So the low T, they are the ones which will be able to pick up a small amino acid peak, which happens at zero point 0.8, zero point 0.9 ppm, which usually is getting suppressed at the intermediate or high T. So it depends on the how you are seeing or what are your or clinical or imaging differential diagnosis. If given a chance, you have time, you should go ahead with the low as well as intermediate T. And when you are suspecting some sort of mitochondrial kind of disorder, or if you are looking for a lactate peak, then you should look for always intermediate T, that is 135 or 144 T, which will show that inversion of the peak of the at the 1.3 ppm, which will help you out to differentiate between the lipid and lactate peak. So that's the answer to your question, that if given a chance, you do low and intermediate, and if you don't have more options, then if you are looking for lactate peak, then you should do the 144 peak. Now, another question is that you should use single voxel or multi-voxel for single voxel usually we use when the pathology is like very focally defined. In those kind of scenario, you should use the single voxel, for example, tumor or the lesion which are very close to the CSF or close to the bone, in which you are expected to have a lot of artifacts. So in those kind of scenarios, single voxel we use. But usually in MR spectroscopy, when we are doing for the white matter disease, multi-voxel is good enough, because you can select different areas of brain within that multi-voxel area, so that you have some sort of multifocal areas of brain assessment about the chemical properties. So you can use multi-voxel for the white matter diseases. The other question that I can see here is that how to differentiate myoinositol versus glycine. So usually the myoinositol and the glycine peak is seen at 3.4, 3.5 ppm. So at at 35 T, that is low T, both will show that peak at the 3.5 or 3.6 ppm. But when the peak persists at the 144 ppm also, then it's usually the glycine peak, because at 144 peak the myocytol peak will be suppressed. But if it were case of some sort of NKH, which is the non-ketotic hyperglycemia, then you will see that the peak will persist with at 144 ppm also. So in that way, we can differentiate between the myoinositol versus the uh, this thing uh, glycine peak. One question I can see that in 3 Tesla MRI there is no inversion of left. No, 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 no. You will see inversion of lactate peak in 3 Tesla MRI also. When you do the intermediate T, you will see that there will be inverted peak. Now going on to the next case. Yeah, here is one child which was some sort of googly or some sort of interesting case. A 9-month-old child who had increase in head size, and the child was being followed on USG, and USG showed that there was some ventriculomegaly. So when the child presented to our pediatric neurologist, the child was irritable and there were clinical signs of raised ICD were present, and there was some doubtful thing about the vision also. So these are the T2 weighted and the sagittal images. So anybody wants to comment or picking up any finding? So what we can see here that there is some sort of mild ventriculomegaly. In addition, you can see that the cerebellar tonsils, they are reaching up to the foramen magnum. So there was some sort of tonsil ectopia. And if you carefully see that there is diffuse calvareal thickening of the skull vault. So based on this finding, it was looking like that we are dealing with some sort of condition involving the bones. And subsequently, these are few more images of the same child, in which you can see that here is the crowding of the foramen magnum by the cerebral tonsil, and you can see that it's diffuse calvareal thickening, which shows T2 and T1 hypointensity. And this finding, and the child also had subsequently assessment, which revealed that child had hyperostonomegaly, and subsequently CT scan was done to assess the bones, and bones were showing this kind of thickening of the calvarium. And if you see the diploic space, which was replaced with this kind of sclerosis of the diploic space, and which was throughout involving the cranial vault as well as the skull base area. And Here is a few more images which is showing the same finding that it was showing some sort of sclerosis of the entire skull vault as well as skull base area. The optic canal, they started showing some sort of narrowing. You can see that 2.1 on the on millimeter was seen in the optic canal. So based on this finding, anybody has any differential in mind, you can put down in the, or what you want to do next. Any guesses what this condition could be? Considering that there is some sort of thickening and sclerosis of the skull vault and skull base area, mild optic nerve canal narrowing have been started. There is evidence of tonsil ectopia, ventriculomegaly, which can be secondary to there might be narrowing of the outlet foramina of the skull base, which is leading to secondary ventriculomegaly. So any have thoughts? Yeah. So most of them you have picked up that this could be some sort of a sclerosing dysplasia, and most of you have written correctly that this is looking like more of a osteopetrosis. So the skeletal surveys was done, and these are the classical finding that we expect in the case of osteopetrosis. You can see that this classic bone within bone appearance uh, in the hand and the foot bones. You can see that this is the skeletal survey of the thoracic rib cage, which shows that there is diffuse sclerosis of the underlying ribs. The long bones also showing that the medullary canal is being replaced with the sclerotic underlying sclerosis, and it is dealing with some sort of sclerosing dysplasia, and these are the classical finding of osteopetrosis. So this was a case of osteopetrosis, which was proven subsequently on genetic basis. Uh, now, now here is one more interesting case. A 6-month-old girl who had a history of fall 15 days back, and the child came with swelling in the head, and child had intermittent headache and low grade fever since last 15 days. And these are the outside CT images that we'll be showing you, which revealed that there was some sort of right-sided EDH and right-sided subdural hemorrhage, right? I'll be showing you the images. Yeah, so are you happy with that? Whatever have been mentioned outside as a subdural hemorrhage on right side or epidural hemorrhage on right side, or you have different thoughts? Okay, so yeah, so most of you have said that this is not looking like some sort of hemorrhage. Few of them have said that this is looking like more of battered baby. For a few have said that this is metastasis, and few have said that this could be hemorrhage. Okay, so when you look at the X-ray, that there was only one time history of fall, and what you can see that the density appears very homogeneous, and it is not that hyperdense. If you expect to be acute hemorrhage, we could have expected more hyperdense appearance. Of course, that depending on stage of the bleed, you can have variable density, but there was no fluid level. It was like some sort of lobulated soft tissue density, which is slightly hyperdense, which was causing compression of the underlying parenchyma. The other thing that it was crossing the suture, and if you see carefully that there's some sort of soft tissue bulge outside also. So if you see this kind of right side frontal area, the bulge is seen on the outside also, and the underlying bone appears to be very irregular jacket margins. And these are the subsequent bone window in which you can see that the underlying marrow also doesn't look normal. It shows some this kind of permeative areas with irregular spiculated Paris reaction. So if it was some sort of after fall, some hemorrhage that we could not have expected this kind of changes, which is seen as a like some sort of speculated Paris reaction and small permeative areas within that diploid space. So that was like some sort of red flag that we are not dealing with simple case of some post-traumatic axial hemorrhage. So for that, subsequently MRI also was done to confirm that we are dealing more than just a hemorrhage. So these are the MRI images. These are the T2 weighted axial and this is the T1 coronal images, in which you can see that the these were looking like more of a epidural or epidural lesions which were having this kind of lobulated margins, and the central part of the lesions was showing T2 slightly ISO to slightly hyperintensity, and on T1 they were also again ISO to slightly hyperintense. In between, you can see that these were the striations which are T2 hypointense, and they were quite marked. They were seen multiple bones, frontoparietal as well as occipital bones. Here we can see that at the posterior fossa, inferior part, you can see that similar aggressive looking soft tissue lesions. And these are the post contrast images, which shows that there was enhancement, heterogeneous enhancement, and associated dural enhancement. And these are the DWI and corresponding ADC images. So DWI, we could see that there was involvement of the they were looking like very cellular lesions, uh, more of a some sort of high grade lesions because it was showing some sort of low ADC, which indicates that varicellular tumors. And these are the speculations that we can see within that lesion on SWI images also. So considering this, then and the lesions were like they were multifocal. They were not restricted to one of the bones. They were showing multiple bone involvement. So that was indicating that it was looking like more of a diffuse metastatic spread rather than just a primary bone tumor affecting only one area. Because sometimes bony sarcomas of the calvarium can also look like this thing. Ewing sarcoma of the calvarium can look like this thing. But usually the Ewing sarcoma, it will be localized. It won't be this kind of generalized, which is affecting the multiple parts of the calvarium. So based on that, it was look like more of a metastatic disease. And uh, this was the USG appearance, which revealed that it was solid hypoechoic, and you can see this kind of speculations within the lesion. So subsequently, workup was done. USG abdomen was done initially just to look for any mass lesion in the abdomen. And when we saw the USG abdomen, it was obvious or quite frank that there was a lesion in the retroperitoneal space. You can see that centrally this is the aorta, this is the vertebra, and lobulated heteroechoic mass lesion was there in the retroperitoneum on both sides. which was uplifting the aorta, and it was encasing the major vessels of the abdomen and mesentery. So considering the location and the calvar lesions, it was assumed that this was look like more of a neuroblastoma in the retroperitoneum, and the calvar lesions are looking like metastasis. And biopsy was done from that superficial scalp, solid looking lesions under the USG guidance, and it came out to be a round cell tumor. And subsequently, investigation was done, and it came out to be a neuroblastoma with metastasis. Right. So not all extradural or epidural lesions are hemorrhage. You should be aware about clue towards it, which are they looking like more of a masses, or which are looking like some sort of hemorrhage, right? So here these were the some sort of take-home points, that not all hyperdensity uh, is hyperdensity is like hemorrhage, right? Uh, Somebody is asking about the significance of punctate fiber hyperintensity in infant to tell come across how we should be reported as UB or white matter injury. I mean, this looks like a kind of very vague question. So basically, in infants, first of all, you should be aware about that. What are the areas which are myelinated and which are not myelinated? And sometimes, like I'm not sure what you are talking about. Are you talking about some terminal zone of myelination, or sometimes you will see that when you see very focal areas of subcortical, very tiny signals in this, that we usually mention as UBOs when it is not correlating with the clinical findings. But usually when the lesions are very patchy or confluent, then those kind of thing, and they are not myelination appropriate, then those are the abnormal finding. They should not be reported as UBOs, right? So I'm not able to clearly understand what kind of lesions you are talking about, but I hope this gives some clarity to your question. Now, moving ahead, here is one some sort of very complex case that we had come across in our institute. So here is 8-month-old boy who had headache since 3 weeks, vomiting for 2 weeks, fever was low grade, and presentation, neck rigidity and Kernick's and Broditsky signs were positive. And based on this finding, it was suspected that it might be underlying infection. So that initial the glucose was 42 and protein were high, and there was cells in the CSF which lumbar puncture was done, and it was showing that high WBC. And the patient had taken some sort of oral antibiotics 2 weeks ago, and it was treated as partially treated meningitis. So after coming to the our hospital, CSF culture, viral panel, everything was sent, and these are the imaging appearance when the child was imaged at our hospital. So what we can see here that these are the T2 weighted, the diffusion weighted images, and this is the flare post contrast images. These also flare pre contrast and post contrast images. So what you can see here that there on post contrast images there is some sort of circle space enhancement, which is also seen in the basal exudate, basal region in the bilateral CP angle system. So based on this finding, what will be your initial thought you would like to put in the chat box? Somebody was asking, the can it be meningoma? Again, meningoma in pediatric age group is not that common. Like so, when you are thinking of meningoma in the previous case, you should be very sure that unless you are dealing with some NF2, it's not common that meningoma present with at this early age. So previously case meningoma not a differential, and as we have seen that multiple bones were involved, so that also rules out that possibility of meningioma in those kind of scenes. So yeah, now in this case, I can see that everybody is saying that most of you are saying initially there's a meningitis, which could be secondary to pyogenic or TB or viral or fungal. Okay, so those thoughts are valid. Somebody has mentioned lymphoma. Lymphoma directly at this presentation we could not have thought because we don't have like clear cut evidence of any markedly mass-like thing. So that we could not have thought of at that presentation. So yeah, we also thought that this looked like more of a meningitis kind of appearance, which could be secondary to infection. And so uh, after that antibiotics, there was no symptomatic improvement. Persistent vomiting and headache was there. And after that, steroid was given. So after giving steroids, there was some mild improvement was there. And repeat CSF was done. So repeat CSF also revealed that protein were showing some sort of increase. The WBC has reduced over time. But during the CSF investigation, the gene expert, pyrosequencing, cytosine, everything was negative. Even at the time, it was checked for some sort of malignant cells. But it was negative. And MRI brain was repeated. And considering basal exudates and all, TB was thought of because sometimes TB may not be picked up on CSF. So AKT was started, and uh, after that. Mother also had some sort of past history of TB, and which the mother had taken AKT in the past. So based on all this thing, TB was started, and patient was discharged after symptomatic improvement. But after some discharge, patient again admitted after 2 days with headache and vomiting, and MRI was done at that time. And at the time, these are the imaging finding in which there was some sort of ventriculomegaly affecting the bilateral lateral ventricle. And if you see that, despite of starting of that AKT initially, you can see that there was increase in leptomeningeal enhancement, and the basal enhancement also was looking more and more marked. And the enhancement along the salivary fissures, and the apochlea also was increasing in size, and the ventricle size also has gone up. So that indicates that the treatment was not responding. So and again, so after this thing, the child was not improving, and the BP shunt was put. And after putting BP shunt also, the child again present with some sort of right side facial weakness and suspected stroke. And these were the MRI imaging at that time. So despite of putting BP shunt, the ventricles are not being drained, and you can see that there is some sort of CSF field collection which was formed in the parenchyma at this along the tract of the VP shunt. That means that whatever that CSF were containing, which was containing high proteins or high cells, which was blocking the CSF absorption or CSF drainage to the VP shunt. And these are the few more images which were taken at that time. And at that time, we started noticing that there are something unusual things which has flared up in this scan. The things which were unusual was that you can see that now the basal meningitis, they have formed into some sort of nodular looking masses in the CP angle systems, and you can see that now mass like enhancement in the bilateral CP angle which has progressed over time. And if you see that there is unusual disproportionate widening of the sulcal spaces in the upper ocular region and the sylvian fissure, which are also every time we have imaged after giving all the treatment, it was increasing in size. So now we were thinking that we might not be dealing with some sort of infection or inflammatory thing. This might be something else. And these are the T1 weighted post contrast images, which shows that extensive nodular looking leptomeningeal enhancement, and this kind of thick leptomeningeal enhancement, which is along the surface of the brainstem and also extending into along the spinal cord. Uh, and so these lesions which were seeing in the bilateral CP angle, they were looking like more of a mass-like thing. So after this scan, we have started thinking of this could be some sort of neoplastic conditions after ruling out everything by doing CSF investigations, and no improvement on imaging after giving all kind of antibiotics, and even after the TB treatment. And you can see that every time we have imaged the child, the sulcal space were like disproportionately being widened, and every time the basal lesions were, they were showing some sort of increase in size despite of all treatment. After that, once upon a time, we also did the spine screening, and the spine screening revealed that there was significant some sort of cake kind of leptomeningeal process along the spinal cord. In the thoracic cord, the lesions were not separately identifying for the cord parenchyma. And these are the post-contrast T1 weighted images in which you can see that very thick looking, mass-like looking leptomeningeal enhancement along the surface of the cord. And these are the T2 weighted images at the at the lumbar region, which also shows that there is nodular thickening and clumping of the coracoid and roots. So now more and more we were in favor towards some sort of um, uh, a neoplastic etiology. It could be some sort of diffuse metastasis, or it could be we also thought of some sort of high-grade variety of uh, that leptomeningeal glioneural tumor, as it has progressed within 1 month, like from some sort of mild meningitis, and now we are dealing with some sort of very frank, aggressive-looking leptomeningeal spread of the disease. So we also thought of some sort of high-grade variety of uh, leptomeningeal glioneural tumor. So this was the differential that was made, and these are the lesions which were seen along the surface of the spinal cord, which were also looking very nodular and mass-like looking. So subsequently, it was thought that we had some sort of multidisciplinary discussion in our hospital, and it was thought that we should get biopsy. And the lesion which was showing around the along the surface of the thoracic spinal cord and along the leptomeninges of the spinal cord, they were looking much more areas of mass-like looking lesions, and they were the one which can be easily assessed. So this region was targeted, and biopsy was taken from those area, and that biopsy revealed that it was high-grade undifferentiated malignant tumor, possibly of high-grade glioma. And after IHC workup, it came out to be a diffuse midline glioma, which is H3K27B altered. So that was very unusual presentation of diffuse midline glioma. Usually, we expect diffuse midline glioma to be involving the structures which are in midline, like thalamus or brainstem. These are the or structures which are in midline in the supra or infradental lesions. This was very unusual case in which the child started with some sort of leptomeningitis, and then subsequently we could found that there was progression of the leptomeningeal spread of the disease, and which ultimately turned out to be this kind of DMG H3K27B altered. So that was very rare thing that we have come across. But the clue is that when you see that despite of your treatment, when you see that there is no improvement on the scan as well as clinical, and the lesions that when they look like more of an outlier or mass looking like, and when you see that disproportionate enlargement of the cerebral circle space, which indicates that there is an infiltration of the cells, so that could be a red flag that we might be dealing with some sort of neoplastic disease, and if needed, then biopsy has to be done to look for the correct answer, right? So that is the post-op images, which shows that this is the area from which the biopsy was taken, and subsequently also you can see that there is disproportionate widening of the cerebral circle space surrounding the opercular regions of the bilateral cerebral hemisphere. Right. So there was some sort of atypical case that we have come across recently. Yeah. Then again, looking for the tumors. Now I'll be showing one more case of that. Here is 7-year-old boy who was firstborn of non-consanguineous marriage, and the child was having some sort of on and off mild grade headache since 2 to 3 months, and last 1 week the frequency had increased. Ophthalmologic examination revealed that there was bilateral papilloedema, and the child was referred to our hospital. Uh, Developmentally, the child was like age-appropriate milestones were there, so it was not looking like some sort of white matter disease. But the child had some sort of birth history, like it was a preterm child, and there was history of prematurity, and the germinal matrix hemorrhage was there in the past. On examination, that there was some sort of left hemiplegic gait, left upper limb dystonic tremors were found. So we were expecting that the pathology should be on the left side, and these were the images in which you can see that there's a well-defined a solid cystic lesion in the left-sided high parietal and the perirrhinic region. Uh, so when you are dealing with the some sort of neoplasm like thing, a few things we have to mention that is there any perilesional edema, and what is the nature of the lesion, whether the lesion is solid or cystic, and you should see the DWI images, which is the most important factor that whether you are dealing with high grade lesion or a low grade lesion, and you should also look for ancillary sequences like SWI. So here is one of the lesion which is is well-defined rounded lesion which has got areas of solid component as well as cystic component. And you can see that these are the DW and these are the ADC images, which shows that the solid area shows high ADC and corresponding, sorry, high DW and corresponding low ADC values. And the solid component also showed multifocal areas of blooming, such as of hemorrhage or calcification. And these are the phase images. On phase images, it was looking bright, so that was calcification for us. So it was looking like more of a high grade lesion, which was having areas of microhemorrhage plus calcification. It was having this kind of disproportionate edema. You can see that usually the low grade tumors, they do not have primary lesional marked edema, but in our case, you can see that there was disproportionate vasogenic edema. And on post contrast images, you can see that the solid areas of the lesion was showing heterogeneous enhancement, and the periphery of the lesion also shows enhancement along the walls. And these are the perfusion weighted images, which also useful to look at the performance parameters that also can indicate that whether we are dealing with high grade or low grade. And the solid areas at mark with the red color on the perforant color coded maps, it was showing increased areas of perforant in this case. So considering the age and the location, it was looking like more of a high grade tumor. So at that time we gave possibility of it can be some sort of supratentorial ependymoma, which can have areas of calcification, which can have solid cystic appearance, and it can be very aggressive, can show restricted diffusion, or it can be some sort of ATRT, which was, but usually ATRT usually present less than 2 years. It usually present in infancy or early childhood presentation, or it can be some sort of high grade glioma, those kind of thing that we were thinking of. And these are the MR spectroscopy images, which showed that the choline was elevated and Na was quite low. So the choline and Na ratio was more than 2.2. That was also indicative of high-grade phenomena. And the cystic component was showing lactate peak, which was quite obvious. And it was planned that this lesion has to be removed surgically, so that DTI was done. So DTI revealed that the corticospinal tract on the affected side, they were displaced anteriorly. As you can see that these are the sagittal images, and these are the corticospinal tracts. So that you can see that this one was causing anterior and compression and splaying of the corticospinal tract. Here is that inferiorly it was displacing towards the midline. Uh, uh, so that was very important when you plan to have surgery. So because the surgeon has to preserve those kind of corticospinal tracts, and the lesion was removed in toto, and it was sent for histopathological, and that revealed to be ependymoma, which was CNSWH grade 3. So these are the some sort of image sequence that you can use in a case of neoplasm. And this was a case of supratendural ependymoma. Just for the sake of academic interest, they can be uh, remembered as 1, 2, 3, 4. So one is like it's a single large tumor which is common in first decade, and 2P means like you can have perilesional edema and periwinkle sign that we saw. You can have 3L, that is the large lobulated lobar mass, which we saw. And it can have 4C, that is the central chunky area of calcification and large peripheral cyst. So these all findings were positive in our case. So uh, that was this thing of supratentorial ependymoma, right? Now, again, coming with some sort of leukodystrophy kind of case, a 9-month-old child who had come with irritability, and there was some sort of increased head size. And these are the MRI and CT images of the same child. So, anybody would like to comment that what we are dealing with, or any possible diagnosis on this based on these imaging findings? Anybody would like to comment? Okay, so I'm getting mixed response between ALD, Alexander, uh, ACARD. So, first of all, that I have told you that the child had large head size, so ACARD syndrome is not likely. they usually present with microcephaly. And if you see here that there is predominance of the white matter hyperintensity, which are more in the frontal area as compared to the occipital region. And if you see that there are some sort of cystic looking lesions in the quadrant nuclei in the basal ganglia. And if you see carefully that there is some sort of this kind of T2 hypointense linear band kind of structure in the periventricular location. And that band kind of structure, it is showing enhancement on the post-contrast images, which is known as Galen sign. And when you see this kind of frontal predominance, hyperintensity, when you see this kind of basal ganglia, cystic looking lesions, and this periventricular rim of enhancement, which is T2 hypointense, when in this early age of presentation, then this is a case of Alexander disease. So this is a infantile onset Alexander disease. It's a fibrinod rare fatal leukodystrophy which present with microcephaly. So on MRI, when you see this kind of 4 out of 5 criteria that fulfills to label that child as an infantile onset Alexander disease, in which you will see that cerebral white matter abnormality which are having frontal predominance. You will see a periventricular rim which is T1 hyperintense and T2 hypointense. You might see abnormality in brainstem. You will see abnormal swelling or volume loss in the basal ganglia, and sometimes you will see cystic lesion also. And you might see contrast enhancement in the optic nerves, periventricular rim, or white matter in the frontal lobes, which were present in our case. So this was the infantile onset Alexander disease. Right. Now, maybe one or two cases I can show you a few just for the next 5 or 10 minutes, and then we can wind up the session and we can take some more time. So here is 7-year-old boy who had generalized tonic-clonic seizures at 1.5 months of age. The child had delayed walking and frequent falls since early childhood, and there were tremulous movements during initiation, difficult in writing. There was no significant birth histories, but delayed development was there. And these are the MRI images. If anybody can find anything, you can put in a chat box, or if anybody knows the diagnosis, wow. So one of you have written already. So first, I'll be telling you the findings of this patient so that when you are looking at the level of brainstem, you can see that this kind of linear T2 hypointence striations in the pons, uh, which looks like almost trigrowed in the pons area. You can see that the pons appears unusually large, bulky, and when you look at the midline vermis area, you can see that the vermin there is some sort of atrophy of the vermis, which is more marked in the superior vermis area with widening of the interfolial space. The splenium also appears more of a vertical in orientation, and there is some sort of axial cyst, arachnoid cyst in the posterior fossa, and this is corresponding to two-weighted axial images, which shows again that T2 hypointensity in the pons in the paramedian aspect. Uh, so what is the diagnosis in this case? Am I dealing with the Friedreich's ataxia or INED, or it is some sort of autosomal recessive spastic ataxia of the Charlevoix segmentae, or it is spinocerebellar ataxia? Anybody wants to answer? Yeah, so the correct answer is C. That is the that we call as a short form of R6. So these are the imaging finding. What we usually see in the R6 is the you will see hypointense striations in the pons, and sometimes you will see that hyperintensity along the lateral aspect of the thalamus. And in addition, this patient can have verminal atrophy, which is more marked in the superior aspect, and that you can see on the coronal image also. They can have enlarged pons, and usually the R6 can have this kind of pathognomonic ophthalmoscopic finding also, that they will be showing thickening of the peripapillary retinal nerve fiber layer, and clinically they present with early onset triad of cerebellar ataxia. They have lower limb pyramidal tract signs, and that we saw in our case also, and axonal demyelinating sensory motor peripheral neuropathy. On imaging, you will frequently see arachnoid cysts in the posterior fossa, which was there in our case, and you will see some sort of cerebellar atrophy, which is more of a affecting superior vermis mode. You might see thinning of the corpus callosum and thickening of the middle cerebral pedicle in those kind of cases. Uh, a close differential would be INED, that is the infantile neuroaxonal dystrophy. But in a classical case of INED, you will see that there will be atrophy of the cerebellum, which is diffuse, and you will see that the cortex of the cerebellum which will be bright on T2 and flare images. The other typical finding that this is the clava region that will be hypertrophied in a case of infantile neuroaxonal dystrophy, and the splenium will be more of a slanted appearance, and those patients also have optic atrophy, as you can see in the thinning in the as shown in these images. So that is the optic chiasma in a normal reference patient, and this is the patient with INED which shows optic nerve thinning, and that is the usual cerebellum how it looks like on Excel images, right? So I guess our time is over. So I would like to conclude today's session. And if next time we'll be seeing some more few interesting neuro cases that we have seen come across with some sort of teaching point. So thank you for attending. Uh, and one of the question that now I'll be going through the some sort of questions. Uh, so criteria for the optic nerve thinning. So usually it is more of a qualitative, but when you see that in the orbit, in the intraorbital portion, when the diameter of the optic nerve is less than 2 millimeter, then we can say it as a optic nerve thinning. But you should only consider the optic nerve, but you should not measure the optic nerve sheath within it, so that we can say somebody's mentioned hypomyelination versus leukodystrophy. So hypomyelination comes under the spectrum of white matter disease, and usually hypomyelination uh, they are primary or secondary. So the primary hypomyelination, it affects the entire brain and parenchyma, involves the cerebral as well as cerebellum in most of the cases, and you will be seeing some sort of slightly hyperintense white matter on T2 weighted and flare images, and you will see T1 iso intensity or slightly hypo intensity in those kind of scenario. And in a case of this myelination that you made by leukodystrophy, is that this myelination is much more brighter and on T2 weighted images, and they are usually more T1 hypointense, uh, T1 hypointense as compared to the hypomyelination. And in this myelination or leukodystrophy, you will see that normally myelinated area, especially when it is not global, so that will be a clue that it looks like more of a dysmyelination rather than hypomyelination. The peri-wrinkle sign and peripheral cyst. Okay, that I'll show you on the images. Uh, so when you see this kind of central wrinkling appearance of the solid tumor with surrounded by the cystic changes, that is called as a peri-wrinkle sign, and this is the peritumoral cyst that we can see here, or peripheral cyst. So these are the sign which is classical for the peri-wrinkle and peritumoral cyst area, right? Then yeah, somebody is telling that thank you for the cases, and how can we approach for the discussing difficult pediatric cases. I can share my email ID. You can contact me. You can put down. I'm just putting down in the chat box my email ID so that we can take it further if you have any difficult cases or interesting cases that you want to share or discuss. Uh, so that's my email ID for if you want to if you have some queries or if you want to show some difficult cases, of course we can see that. So thank you for all for attending the today's session, and I hope it will be useful. The other question that somebody